Good evening. Welcome to another episode of our month-long e-conclave on breast cancer brought to you by the IHW Council and Novartis India. I'm Anisha Nair Dhawan, your host for the evening. In today's show, we will discuss the role of palliative care beyond the end-of-life care for breast cancer patients. But before we start the discussion and welcome our esteemed panelists, here's a snapshot of all the ground that we've covered in the Breast Cancer Action Month, addressing India's breast cancer epidemic, moving from awareness to action. We kickstarted a month-long campaign on 1st of October, and here's a quick recap of what the experts have said on our show so far.
Breast cancer is the number one type of cancer in women today. To exhort and encourage all of us to move from awareness to action, ISW Council, in partnership with Novartis India, embark on month-long mega virtual conclave, Breast Cancer Action Month.
Awareness around cancer, awareness around women health, awareness about around all the artificial things that we engage in, and vanity has its own impact on our health. And I think it's time to turn the tables on the other side.
At the moment, the issue is that three factors. A, do not recognize when it happens to them. B, when they recognize, they take so much time to report that it becomes late stage. And C, that what kind of treatment are available and they receive finally.
Why do you think that the people in US, they are diagnosed stage 0? 80% of the ladies, the disease is diagnosed in stage 0, 1 and 2. While in India, it is 80% stage 3 and 4. Why? Only one reason, the awareness.
The problem is really at two levels. One is, like I said, with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
You know, the single biggest risk factor for all cancers, including breast cancer, is aging. If you live longer, then you are more predisposed to get all kinds of non-communicable diseases, including cancers, including breast cancer.
Overall, what is important in saving life is the cure of disease, which is important as surgery, chemotherapy, radiotherapy, and hormonal therapy. And, most of the cancer center, like in state and the central government, now gives all the essentials treatment free of cost. You can get it. The major problem is the long waiting list, which is, and everybody should be given a fair chance to live with the disease.
Essentially, our emphasis should be, if we can do the awareness, do the best early detection, if we can downstage the disease from stage 4 to stage 3, stage 3 to stage 2, stage 2 to stage 1, even about 20% of patients suppose we downstage them, then I think for last coming 5 years, our job is done.
Our country, I think that part of the thing where we have to go and educate people so that they can do self-breast examination is very important, and we're doing our bit in terms of going to smaller villages, educating, and we are also working with ASHA workers. I know, there can be various views, but they reach people in their houses, right? So somewhere we have to use the existing infrastructure, train them. All of them may not be 100%, but we have to make that effort to ensure that we get self-breast examination and remove the stigma around self-breast examination.
It is very natural to panic when somebody very close to you, undergoes cancer. And I think for that reason, it is very important to know your right sources of information.
To fight against breast cancer, we need awareness and action at all levels. And to make every woman and man become the ambassador of good breast health, we at IHW Council have begun a mass movement of taking a pledge that each one of us will talk about breast health with at least 5 people in our lives. the lawmakers, social influencers, social leaders, and medical experts who have been joining us to chart out the way forward to prevent breast cancer in India have also shown their exceptional support to this campaign. We're also thankful to Novartis India for its support for this movement. We request all our panelists today and all of you joining us, listening to us, to please sign this pledge by clicking the link in the comment box of this live post. There's a link there, just click on it. It will take you to the pledge where you can sign this pledge. And you can also sign this pledge by clicking the link in the comment box of this live post. And please welcome Dr. Dinesh Bhandharkar, Director, Subodhya Cancer Institute and President of the Indian Society of Oncology. Apologize for a little bit of technical issues, connectivity issues at my end. But I would request everybody watching to please go ahead and sign this pledge to make India breast cancer free. You just need to click on the link in the comment section of this live post. You can even go on the website ihwcouncil.org and sign this pledge. And once you do sign this pledge, please share it on your social media handles and involve 5 people by tagging them to make this post a viral one so that all of us become aware of breast health. Now, let's get back to the topic of the show today. Now, for many days now, we have discussed treatment of breast cancer in our country. Now, palliative care is also very important for cancer patients. This is a special type of healthcare for people with serious illnesses. Its goal is to improve the patient's quality of life. Many times, palliative care is associated with end-of-life care for patients with advanced breast cancer. It may not be possible to give stage 3 or stage 4 advanced breast cancer patients curative treatment, but much can be done to prolong their lives and make it worth living. Even for those with early stage cancer, palliative care can be used to help prevent and relieve symptoms and side effects related to cancer and its treatment, such as pain, nausea, and fatigue. In India, who is responsible for palliative care of breast cancer patients? India currently has a doctor to patient ratio of 1 to 2,000. Do cancer care centers have enough doctors, nurses, physician assistants, counselors, and dietitians to ensure that breast cancer patients have access to pain and symptom management and receive emotional, social, and spiritual support? These are some of the issues that we will discuss with our esteemed panel today. So please welcome our esteemed guests. Please welcome Dr. Dinesh Bhandharkar, Director, Sarvodaya Cancer Institute and President of the Indian Society of Oncology. We also have with us Dr. Geeta Joshi, CEO, Community Oncology Center, Gujarat Cancer Society, Ahmedabad. We are happy to have Dr. Shrikant Tiwari, Medical Oncologist, Jawaharlal Nehru Cancer Hospital, Bhopal, joining us. And please also welcome Dr. Suresh Babu, Medical Oncologist, Fortis Cancer Institute and Associate Professor, KY Memorial Institute of Oncology, Bangalore. And we also have with us Michaela Lindborg, Senior Director, Group Patient Advisory, Novartis, and she's joining us all the way from Switzerland. A warm welcome to all of you. Thank you so much for joining us on this show. So let me start with you, Dr. Tiwari. What is the role of palliative care in the lives of breast cancer patients in our country? Okay, I think Dr. Tiwari is not here. So Dr. Babu, could you answer this? What is the role of palliative care for breast cancer patients in our country?
Actually, palliative care is the very important specialty for any cancer, not only breast cancer. Unfortunately, it is not most neglected specialty in our country. See, many patients may not require chemotherapy, many patients may not require radiotherapy, but every patient, some or the other time, they require palliative therapy. So palliative therapy is a very, very important. The public perception is that palliative therapy is given by only doctors and medical personnel. No, more than doctor or medical personnel, the other people are very, very important people in palliative care. Palliative care is not about treating only pain, nausea, vomiting. Palliative care is also about giving the social comfort, confidence, everything in the patients. So unfortunately, in our country, we don't have so much developed palliative care as of today. So palliative care is a very, very important. As far as the breast cancer is concerned, palliative care is something to give them comfort from the pain or any other symptoms, and also give them the confidence and make them more, independent in the, dealing with the cancer. That is about the palliative care in brief.
Right. Dr. Tiwari, Dr. Babu saying that we don't have very well developed palliative care in our country, and it's not just the doctors who are responsible for it. So, who all can be involved in palliative care? Whose responsibility is it to ensure the emotional, the spiritual well-being of cancer patients, especially breast cancer patients who are undergoing therapy, whatever stage they may be in? Because as far as breast cancer is concerned, there is a lot of stigma attached for some people to it. So there are a lot of emotional issues they have to deal with as well. So who really is responsible for palliative care for breast cancer patients? Dr. Tiwari, I would request you to please unmute yourself and answer the question.
Okay, am I audible?
Yes, we can hear you now.
Okay, as you listen, Dr. Suresh, what he said, totally agree with that. Look, palliative care it is a basically approach, like in other medical science, like with cardiology or oncology, we approach the patient. So palliative care is also an approach, and this approach doesn't mean that it is only for those patients who having end stage of life. So it is basically an approach towards the patients, family members, or whoever, so caregivers. And the main focus is the optimal management of the distressing symptoms related to the cancers. Apart from that, the management of the psychological issues, spiritual issues, social, as well as the financial issues, according to the patient belief, socioeconomic strata, backgrounds, educational status. And the main goal of the palliative care is to anticipate. It's very important that you should anticipate, you should prevent, you should reduce the suffering of the patients. So palliative care should be a start, whether it is the breast cancer or any other cancer, it should start from the diagnosis. It is not means that when all the treatment has been over and now there is no treatment is left. So the patient is bedridden, then you start palliative care. Palliative care should basically start from the diagnosis, because patient required every support at every, like whether the patient is on active chemotherapy, whether the disease is curable or non-curable, the patient requires palliative care. And it is a holistic approach. It required the primary care physicians like oncologists, it required the pharmacists, the psychologists, the spiritual, the persons who can also be involved in that. So it's basically a teamwork. And it the diagnosis until the end of treatment, whether it's the curative or as a palliative. For example, if I'm saying the young girls who is having breast cancer, even if it is a curative in the setting, but before starting treatments, the patient are in so much distress due to disfigurement of their body, due to surgery, hair loss, due to chemotherapy. So the distress is so much. So the care should be start from the beginning, whether it's the palliative or the curative setting, and it is the holistic approach. So a lot of teamwork is required.
Okay. Dr. Penderkar, Dr. Tiwari is saying that a lot of teamwork is required. But in our country, there's so few oncologists. Okay, the oncologists have to tailor make treatments now because medicine has evolved so much. Dr. Penderkar, can you hear me? Can you hear me,
Hello?
Dr. Penderkar? Can you hear me, Dr. Penderkar?
No, I can't hear you.
Okay, if I speak a little louder, is this better?
Yeah, no, okay, go ahead now.
So, Dr. Penderkar, I wanted to understand.
Yes.
Dr. Tiwari is saying this is a teamwork, but in our country, we have so few oncologists for the total number of population. Who will take the load? Can the oncologist design the treatment because these treatments are now getting more personalized, and then the palliative care can be assigned to other members of the team?
Okay, so one thing we have to understand that palliative care is a teamwork, but it can be planned. You really do not need large number of oncologists to plan palliative care. You don't need only oncologists to plan palliative care. Palliative care is a fairly standard treatment, and palliative care actually needs to be delivered not by an oncologist, but the supportive staff. So what we actually need to develop palliative care is a paramedical staff which is well trained in palliative care. I don't think there is any uh, paucity of a paramedical staff. So paramedical staff needs to be involved in palliative care. The doctor has to be involved on day one in the planning, and during medical emergencies, we can refer back to the doctor. So what you need is a system with one oncologist controlling the paramedical staff, and there is no need to increase the number of oncologists to give palliative care. It's a concept. And remember, the concept of oncology care, palliative care in oncology is it starts from the day of diagnosis and ends with life. So palliative care goes all along through continuum of oncology care. And through this continuum, the only backup system is a paramedical staff which is going to help us. So please understand, we just need a good trained paramedical staff working in team with an oncologist to deliver palliative care. The other way of doing is, the biggest problem with palliative care is, maybe there will be a question later on, but let me tell you frankly, the majority of the palliative care is delivered close to home, because palliative care, if we want to solve the whole palliative care from diagnostics up to end of life, it is not possible. So let's make it in stages. The biggest requirement of palliative care is at the end of life, or when the cancer is very advanced, and at this stage a patient is situated close to his home. So if at all we are thinking of developing palliative care, we have to create the systems which would offer a service close to his home. So cancer centers are not the solution of palliative care. So we have to decentralize care, and the care has to go to periphery where patient lives, because patient cannot travel from there. So what we should involve is a system. We should create a system where the peripheral paramedical staff, the peripheral general physician needs to be involved in the cancer care and given a responsibility of a training and a responsibility of palliative care in conjunction with the cancer centers. You cannot drive a cancer center to the periphery. It is not feasible.
Right.
So let us understand that delivering palliative care is absolutely feasible. Delivery of care close to home is absolutely feasible. The system can be very easily developed. Only required is our willingness to develop such a system. We do not have paucity of the workers. The workers are available, but we have to put it into the system. Thank you very much.
Right. Dr. Geeta Joshi, let me come to you. Dr. Babu said that, it's not very well developed in our country. Dr. Pindarkar is saying there are enough people in the medical system to give palliative support. It doesn't, all the work doesn't necessarily end with the oncology team. But he added another caveat that most of the palliative care is done closer to home. Now, how do I get the medical staff, if not the oncologist, the nurse closer to home? I mean, the nurse may know, but I mean, how do I get her closer to home? who are the other people who could be trained so that they are accessible to a patient closer to home?
Uh, uh, I have few things to add about the concept of palliative care. Actually, palliative care started with the concept of hospice, moved on to palliative care, and now palliative medicine. It is a specialty. So it is not only paramedical's job, it has a doctor, a paramedics, a counselor, a psychologist, a, a physiotherapist, or whatever team you want to make. So palliative care is a special subject. It should have a separate department, separate OPD, and a trained doctor and staff, all other staff members trained in palliative care with correct approach to deliver palliative. Pendarkar, that as the disease advances, patient needs palliative care right at doorstep. That time, palliative care can be given by the trained staff, nurse, or a volunteer, or a social worker. And there is an important role of volunteer, who is staying in the nearby to the area of the patient and who should be trained in palliative care. So towards the end of life, pediatric care needs to be taken from center to the home of the patient, and that is the right way. But the throughout in process, all these staff should be trained. Now, Government of India has come up with a health and wellness center plan. So each sub center and PSC will have a health and wellness center where palliative care can be is one of the component of the many healthcare programs delivered by Government of India. In this, all the nurses, PSC, ANM, nurses, paramedical staff, and even pharmacists should be trained in palliative care about handling the particular drugs, analgesics, which is required for the palliative care treatment. So at village level or at a grassroots level, the nurses, ANM, pharmacists, volunteers, social workers, all these people should be a part of team and they should be trained.
All right. Training is, of course, very important, and closer to home is very important. Michaela, how do patients get the most out of palliative care? They are suffering. Though, cancer is such a disease that leads to a lot of suffering. And, they sometimes even feel hesitant to tell the doctor of their symptoms. They, in India, they're so grateful that they're getting treatment. They are hopeful that they may lead a longer life, that they're like, okay, forget about the discomfort. I'll just take the medicine. So, how do you get the most out of palliative care?
Yeah, I think the first point I would like to make, you get most out of palliative care if you really use the broad definition that was just described, that really ranges in critical diseases, not only to the patient of end stage disease that needs some pain treatment and maybe psychological support, but really a comprehensive approach that starts early with early diagnosis. And one of the things that can help is also to have groups involved in palliative care, like patient organizations, like psychological support, who help patients to communicate about their disease, about their feelings also. Most important is also to talk about feelings, because very often patients, as you said, hesitate to say what they really feel and what they're worried and scared about. And also including their families, because the family is equally scared and worried. And I think good palliative care would include really this surround sound approach. And we have had experiences where the communication between patients and physicians and family wasn't optimal. So there's data because patients were simply not able to say to a loved one what they really felt, or communicate to a doctor what they really were worried about. So I think to connect that dialogue is an important element as well.
Right. So openly and freely talking to your healthcare provider is an important element of getting the palliative health that you care that you see. Dr. Babu, in India, terminal illness is equal to ventilator support in an ICU, which also adds to the cost of the treatment. Now, how do you see the current awareness about palliative care impacting the financial and emotional costs of treatment? Because, it's in the end not just the patient who is affected, but his entire family is also under stress because of the financial considerations.
First of all, the thing is that the concept that palliative care or any health care is only about the doctors and nurses, that perception must be changed. So we think that whenever you want to give care to any patient, especially the terminal or any cancer patient, the public perception is that it's only the doctors and nurses. And if any patient is there with any other problem, they don't think the other people also can give the care. That perception has to change. In fact, one of the study which was done about 4 years ago in Tamil Nadu, they did in a very remote village in Tamil Nadu. They found that almost none of the people know the term called palliative care. They try to explain about the palliative care, and they also explained that the communities, the good educated people in the community itself can be workers to do the palliative care. Initially, many people agreed. Later on, they dropped off, and they try to give reason of not knowing education or age or all those things. So the palliative care is that something we have to do not one time, we have to give it sustained. Like if some communities are willing, we must keep on encouraging them. And we must show the examples. There are such communities exist and they have successfully given palliative care. When that happens, then the cost, emotional support, everything will come down. Say for example, if a patient who is staying in remote village, if he develops any pain or symptoms, he doesn't have to catch a vehicle and go to city for the care. If he has that comfort that the person who is taking care is staying next to me, it will give more comfort to him and his family also. So that is something we have to create in the family. It will also give more confidence to patient family, and also it will significantly bring down the burden. So in that, what we regional cancer centers are what they are doing, they are trying to do with something with the telecommunications. So, but we need to prepare communities. Especially, we have to find people who are willing to do such work in a village, and continuously and sustainability, we have to encourage them to do that work. And we must encourage them in all ways to do that work. Otherwise, the palliative care will not be sustainable. So, in every village, everywhere, we have to find at least a group of people who are little bit educated, who are willing to work for the people. So, such things will definitely bring down the cost. Every cancer patient need not go under ventilator. Every cancer patient don't have to come to doctor every time. So those things can be definitely reduced. It will also give more psychological and support and confidence into the patient and family. It will definitely reduce the cost and give more confidence to the patient and his family.
Right. Dr. Joshi, I want to come to you. Since you run a center in Ahmedabad, can you tell us how it works in real life? Because, if you're just going to depend on your oncologist to give you all this help, emotional health, spiritual health, then perhaps you'll be left wanting. We want to understand from you your example, because Dr. Babu is saying that you need to involve the community in this, and it doesn't have to be a healthcare worker who's the only one who can give palliative care. So can you tell us what your experience has shown you since you run a center in Ahmedabad?
Yeah. I started working as a palliative care physician at tertiary level cancer center, but I am involved with government of Gujarat in implementing palliative care at PHC and village level. So I will say that first of all, our patient doesn't know what is palliative care. That word is absolutely new for them. And the palliative care is a Latin word. So again, it is difficult for them to understand pronouns and the whole concept. It is difficult to understand them. But once they start coming to us to first visit, second visit, third visit, by third visit, they realize what this is and they feel that we should have been referred to this department much earlier. That is one thing. Secondly,
So, ma'am, I'll just interrupt it. They have been referred to your center. They don't come on their own. Who refers them?
Yeah, the patients who are to my center, community oncology center.
Yes, yes.
Yeah, okay. These patients are referred from the cancer hospital through which my center is affiliated, and a few patients do come directly to my center as they hear about this center by word of mouth. Especially surround their neighbors or somebody, and they will say, okay, oh, now your cancer is advanced, so yeah, your patient is having so much of pain. Why don't you go to this center? They are offering good care and nursing care and other support. So by word of mouth, by the reference from the tertiary care center, and by personal reference through few oncologists as well, oncologists, but not from non-cancer doctors. Still, non-cancer doctors, non-oncologist doctors, they do not know about the palliative care, and they don't understand its importance.
All right, ma'am, I'll come to you again to understand how the community is involved here. But Dr. Tiwari, you I think also mentioned that you have to train people. It's optimal management. Now, where is the training for palliative care coming from? Is it at the MBBS level? Are nurses also trained? Does everybody know? Now, everybody can't be an oncologist, but a lot more medical personnel and paramedics can be giving palliative care. How are they trained for this? Who trains them?
I answered it.
Dr. Joshi, I was asking Dr. Tiwari. I'll come back to you. Dr. Tiwari, I request you to please unmute yourself.
As you heard from Dr. Joshi also, that now palliative care is also totally separate, like other specialty of medicines. Like the palliative care is also the separate entities now, like the doctors who are taking training in critical care or emergency care. So the doctors are also taking training in palliative care. Okay, and yes, and similarly it is also happening with the nurses and paramedical staffs also. Okay, because if you see the burden of the palliative patients, they are increasing day by day, and almost 60 to 80% of if I'm talking about the oncology patients, 60 to 80% of patients sooner or later they go into that stage where they require actual palliative care and then hospice and all these things. Okay, so the training, we as a medical oncologist, we used to give training to our certain section of our paramedics and nurses, then that how to tackle such type of patients. Okay, and there is a separate, in fact, department. If I'm talking about my hospital, there is separate palliative care and hospice department in my center, and there is dedicated team which includes this paramedic, nurse, medical officers, and pharmacist, clinical psychologists. They all used to take round together with each and every patient. Okay, so these are the way. But if you talk about the formal training, like in MBBS level, in MBBS level, or when we are doing postgraduates, there is no formal training for that. There is no formal. At least we have not received any formal training when we have done our MBBS or MD. But yes, when you come into practice, then definitely we used to develop a team, and nowadays many centers who are giving training to the doctors, nurses, paramedicals for this palliative care setting.
All right. So, a lot of people are involved in your center, Dr. Tiwari, for palliative care, and that's very heartening. Dr. Joshi, I'll come back to you to understand how the community is involved here. Because you were telling us about your center where the patients are coming either being referred by a cancer hospital or by word of mouth. But to make this more accessible to everyone in our country, um, community level involvement is required. Dr. Babu also said you need educated volunteers. So how is the community mobilized into this? Can you give us an example, Dr. Joshi?
I would like to intervene if possible at this stage anytime. Thank you.
Yeah.
Ma'am, you go ahead first. Dr.
We have various training programs running at our center, like volunteers training program. It is a 16 hours training program, social workers training program, nurses training program, and all such things. So we train volunteers who are willingly they join this program, and they are willing to serve the community and patients whenever the need arises. So this volunteer can become a link between the center and a community, and can bring the patients from community directly to this. Secondly, we approach all surrounding doctors in our area, like general practitioner, few trust-run hospitals, then urban health center, and all such healthcare setups, where we approach them and tell them that our center has got facility for providing palliative care and hospice care, where they can refer the patient. So this is how we spread the word about our center and palliative care services.
Right. Dr. Pendekar, you wanted to say something on this issue about how the community is involved?
No. So what I wanted to say is, see, we are doing this for last 25 years, and unfortunately, we are very slow in going ahead. So what we have to do is the two important things: create a system, and the only system which is accessed by people at the end of life is a government healthcare system. They do not go to private hospital for treatment or care at the end of life. There is either no money left or no relation left to take the patient there. So the only system which functions is a government healthcare system. So if we want to run a program, and if we really want to help a patient, we have to strengthen the government healthcare system. So we have to create a system. What we have done for this, like in Madhya Pradesh and Odisha, we are trying to evolve with a state level program. So we have created a district palliative care program. On paper, there is a booklet, guideline, everything. At least one doctor from every district hospital and two nurses from every district hospitals have been given a formal approved training of palliative care. So what we are trying to do is, now we have created a person, we have created two nurses, and we are hoping that this will trickle down below to the district, from district to the CSC, PSC level. Unless we create such a vertical system of dispersal of knowledge and empowering these, we will not be able to reach the end user of the program. So we have to create a system, and we have to empower the government health system, and we have to use the already existing government healthcare system to execute any program which we should have a broad reach program. Corona has proven this, that this is the only system works. Go ahead, please.
All right. So Michaela, the way our panelists have explained to us is that there has to be a system whereby, palliative care is given to patients. And of course, it's really critical for everybody at the, end of life care. But, how much do early stage patients require this care? And how closely do they need to work with their oncologist? Because, many people have to travel for the treatment, so they get the surgeries done and they take the initial radiation if required, and then they're not very keen to come back repeatedly for a chemotherapy, and chemotherapy has a lot of side effects also. So for the entire journey of cancer treatment, where can you get this palliative care? I mean, beyond your oncologist.
Yeah, I think what has been said already, and I would like to just reinforce that, is that if there is a surround sound approach, then that's the most effective. And we have, in collaboration with IQVIA and the National Institute of Cancer and Prevention Research of India, published a report also in collaboration with the Confederation of the Indian Industry that gives us a lot of facts and figures. I think to understand the facts and figures and how they compare to other countries already helps to take some learnings. And one of the clear learnings from that is that relative to some other countries, the diagnosis in India happens relatively late, and therefore patients are relatively advanced. So if there was a system, if you talk about a system approach, one of the things that can help patients early on would be to have early screenings, early diagnosis from trained patients to trained healthcare professionals beyond the oncologist, who can really help to strengthen the system. And that's also from an industry perspective something that we are looking into. Yes, we have the treatments, but that's not the only focus. The real collaboration as an industry, we are a stakeholder in the healthcare system, and therefore also look into strengthening decentralized cancer care as another example, or strengthening patient organizations so that they have the means and the needs, the information that they can use to strengthen the patients and give them the psychological support. I mean, I've seen it in my own. Sorry, I've seen it in my own family, and the younger sister of my best school friend was diagnosed at 25. And she was diagnosed because she self-screened and then had the access to screening and then treatment and now is a progressed cancer and was giving up. She was going to give up her treatment. She didn't want to know anything about treatment anymore and said, it's enough, it's enough. And it was only the typical palliative care through the family, through a psychologist, through the GP. The oncologist was there to connect, but it was the other parties in the system who really helped her through it and got her on a treatment. And now she is fit and energized and everything. So she was meant to die and now she lives. So that's for me
this
a
is amazing,
true expression.
really. Yes, Michaela, thank you for telling us about this, your sister's friend's example. Now, one question to you is, Michaela, in the Western countries, palliative care is quite advanced. And there are also patient support groups where, they have their weekly meetings, they talk to each other. There is some amount of emotional support as well. Now, in our country, people are, they're not coming forward. First, they're so scared. Even if they find a lump or something, they're not coming forward. Then, if they're getting treated, they're hiding. They're covering their head, they're hiding, they don't want to talk about it because there's so much stigma attached to it. So, you want to be able, your family also, is left in between a rock and a hard place. They are not trained. They don't know what's going to happen. How do they manage your expectation? So in our country, what do you think would work? Because a lot of these support systems which are there in the Western countries may not work really well in our country.
First of all, I would say you are probably underestimating the patient organization in India. There are some patient organizations who are relatively active, and I think the key thing that can help, and that's probably a learning from other countries, is to work on making patients aware that they can get help beyond the doctor. Of course, the doctor plays a central role in the diagnosis, in the treatment, but for everything else that is not the direct treatment and diagnosis, there is a lot of opportunities also in India. I mean, patient organizations to connect them with doctors or to connect them with the psychological support. And we have had experiences, especially now in COVID. I would like to point out as well, the diagnosis rate and treatment rates have gone even further down because patients are not only aware of their cancer, they are also aware of and afraid of COVID, and the treatment rates on breast cancer have gone down because of that. And I think one call to action also for anybody who has a relationship to a patient, like you said, the 5 people we know of, we should talk about the breast cancer. One of the things is to be aware that 50% of breast cancer patients in India die. And of COVID, it's less than 10%. So I think the need to be active and stay active. And there are patient support groups in India that we also try to help connect so that they now can connect via electronic means. I think that's important thing that we can also take from the Western world.
Yes, so now we are all, coming around to online connections, to teleconsultations with doctors and elsewhere, and this is definitely going to help us go forward. Dr. Babu, Michaela described somebody she knew who had, given up on treatment, but because of palliative care, she not only survived, she thrives today. Now, Michaela also said that in our country, the mortality rate is 50%. That is because so many of the patients present themselves in late stage of the disease. Now, what hope can we give them in our country through palliative care?
So the thing is,
what ideally should we message to them? I mean, should we be clearly telling them that this is or not going to be curative? Should we prepare the family to also help them? How to manage their symptoms of pain, nausea, fatigue? Who will do this? I mean, what should we ideally be telling a lot of these advanced stage breast cancer patients in our country?
The thing is that, as one of the panelists was telling, the most palliative care come to government hospital rather than private sector, more than 90% government sector. One of the very important thing is to grow a system, it will not happen overnight. It will take its time to grow. So what was 5 years ago has not been the case today. See, I will tell you, 10 years ago, 12 years ago, people were not even able to get chemotherapy. Today, all patients have accessibility at least to chemotherapy, radiotherapy, everything because of the various government schemes. So as the palliative care, it will definitely going to improve. So as you was telling, even for example, in government of Karnataka, they have got something called as a palliative care policy, through which each surgeon in a district hospital will be trained with the sisters, and he will train other people in the district, so that the system is growing. It is taking time to grow, but it will definitely grow. So what we have done is that, as we have a telemedicine center, every day one oncologist will go and answer to all the questions, whatever the primary health care center physician is raising or all those things. I just tell them that if you have any problem or anything, whenever they come to us, when they first diagnose, we take time to counsel. So there are many voluntary working in the institution also. So what voluntary groups do is they will take at least 3 numbers of their relatives and the patient, they will keep with them, and they will give their contacts to them. Whenever they go to their own, native or anything, at least they have a cell phone, they will call at least the volunteer, then volunteer will connect to oncologist or a nurse or somebody in a system. And over the phone, we'll try to understand how is the system. Or if they go to nearby PHC, we try to communicate to the doctor how severe is the patient. If the patient can be managed at the local place, we'll suggest them the treatment. If that is not possible, we'll ask them to refer to the tertiary care center. So 95% of the problem can be managed at the local primary health care itself, because we communicate through telemedicine or phone or other things. So whenever a patient is diagnosed with the cancer, the health system is much better than what it was 10 years ago. It is going to be much better 10 years ahead of the line. So it will take time for the system to grow. So over the years, we can hope that we are palliative care, we are going to be a good country for the palliative care. That's all.
All right. So, Dr. Babu, the program being run by the government of Karnataka is commendable, and I believe even the government of Kerala has a very good palliative care program. Dr. Joshi, our panelists have underlined this fact that when it comes to palliative care, most patients will approach the public health system because, of financial conditions, etc., or trust factor. They will go to a public hospital. What is the role of the government here in developing and expanding palliative care? You're working, yours is like, is yours center also affiliated to a government program? Could you say something about what will be the role of the government to expand palliative care all over India? Is it with the central government? Is it up to the states to expand this? Because the government has brought about a few changes in legislation when it comes to consumption of opioid for pain management. So what more can the government do to ensure that palliative care is very decentralized and is available closer to home?
Yeah. our government is working towards this regarding giving the palliative care right at the doorstep and availability of the opioids, very important medications in pain management in such patients. Government has got number of healthcare program in which palliative care is one of the component of those healthcare program, and one particular national program for palliative care. It is a particular program only for palliative care. It is implemented across India in 2012, and now almost 20 states has program running in the 20 states. In government in Gujarat, it is running in almost 14 districts. So, as Dr. Pendarkar had rightly said, that at district level, a doctor and nurse and a social worker is trained in palliative care. A particular module has been prepared for the training, and government has also working towards it by implementation of the NDPS Amendment Rule 2015, by which it will be very easy for an institution or an even district level hospital to procure opioids by this new rule. And so the patient will not have to travel from district hospital or a village level up to the tertiary care hospital to get this medicine and to get this care. So government has rolled down all such programs. Then it is a part of NPCDCS cancer control program also. It is a part of care for elderly program also. So palliative care is interwoven in many programs where now people are at PSC, CSC and district level are aware about what is palliative care. They have received some basic training. There are enough education material is available, and government has also seen to it that this program palliative care can be delivered properly by three components like policy, education and availability of the drugs, right? So government has implemented all these three components, and the patient can have palliative care at doorstep.
Right. Dr. Tiwari, palliative care for patients at the doorstep. How much of a reality is this for breast cancer patients in advanced stages? Dr. Babu also said, it takes time for things to happen. It doesn't happen overnight. But can you tell us what is the situation where you are in Madhya Pradesh? Is it really palliative care at the doorstep? And what is the role of the family members in this? Dr. Tiwari, can you hear me?
So palliative care at doorsteps, really it's nice to hear. But if you... Yeah, I'm hearing you.
Yes, please go ahead.
Are you hearing me?
Yes, sir, please go ahead.
Okay. So look, this is very fascinating that the palliative care at doorsteps is okay, but actually the reality is not like that. What we are saying, I'm not much aware about the this government policy, but look, my center is in Bhopal. If I'm talking about the picture of Madhya Pradesh, my center is in Bhopal, and only we are catering 10 to 15% of the patients residing in the Bhopal. Rest 80 to 90% of patients are coming from the different part, even some part of the Uttar Pradesh and Bihar also, and some part of Rajasthan also. And when they reach in the palliative setting, we used to teach them that you can consult a local doctor for the simpler problem. But many patients used to say that when they approach the local physicians or local any doctor, or even the PHC, CHC also, the doctors even sometimes or the workers, they don't touch him, and they said that, okay, you are having cancer, so we don't have facility, we cannot do any cancer center where you are taking treatment. Even if, because we have taught us all the, we have to tell the primary care physician that you don't require this, the treatment of cancer, you just require palliative care, supportive care for the pain, for nausea, vomiting, and for the breathlessness and all the things. But even still, many patients who are not getting, and sometimes they have to come to the our hospital from 300, 400 kilometers, even in these lockdown periods, just only to get opioid medicine, or just to for the simpler problem like nausea, vomiting, and all these things. So system need to evolve, and the education is must. The education is not only for the community; it is also for the care. If you know the terms, although it's a new term, but it is still exists only in the care can be given to any patients. All the terminally ill patients, whether it's the cardiology patient or the gastroenterology patients, they all need palliative care patients. But they need the education should be spread to the community level as well as the
medical community,
medical level also, medical community also, so that at least the patients should be taken care properly. There is the role of family members. Look, the education of family is also very important. Look, I am giving you just today example. One of our patients, she is just 27 years younger. She is on palliative care. She was doing fine. But suddenly she developed brain mets and unconscious. And today she was admitted, and the family members force us. We have told them that, look, this is the end stage. She has too much burden of the disease in her body. But the family members still say that, okay, doctors, just put her on ventilator support and do whatever you maximum you can do. We have told him that, look, there is no much required of ventilatory support, and we are not going to get much things. But I mean, these are the examples. We have to teach the family members where we should say, no, okay, this is the time. We have to just raise our hand. We have to just pray from the Lord that she should, even if she is going, she should go peacefully. So the education should be given at the multiple levels, the family levels, community level, medical communities, because this term, everyone, the palliative care term, everyone has to understand.
So can I intervene now? Yeah. So what I want to tell you, it is very serious about palliative care. The higher level of government is dedicated to palliative care. Let me use this word. Everybody, the finance is no constraint. As I said, government of Odisha and government of Madhya Pradesh has issued operative guidelines and trained physicians and nurses. So they are serious. Government of Madhya Pradesh has changed the morphine guideline and says that the morphine will be dispensed by every district hospital, because every district hospital has a pharmacy. So government has taken such decisions. If they have not percolated down, that there is a resistance from the lower existing system to these changes. So what we have to do is we have to work at a lower administrative level to accept such changes. Higher administration of the country is all in support for palliative care. It's a phenomenal support, let me tell you. So as far as home-based care is concerned, all of us should remember that government of Telangana has started home-based palliative care in 3 districts. If somebody visits Hyderabad or Telangana, they should visit these home-based palliative care program. It is a phenomenal program they have organized with a nurse, a paramedical staff, going to the patient's house, teaching the relatives how to take care of the patient. I have myself physically visited these centers. That's why I'm commenting on it. It's a unique, excellent model developed by government of Telangana, which other states should accept. Government of Odisha in principle has accepted the program. Just because of COVID, we could not launch it, but a trial program will be initiated as soon as possible. As soon as we said, so the moment for example, I go to Bhubaneswar, we'll be able to push the program. But the government is willing to start it today, and district of Navrangpur in Odisha will be doing a pilot. We would like to duplicate what Telangana has done with some changes. If successful, duplicate in other districts. So government is serious. The home-based care program is feasible in India. It is already happening in Telangana. Thank you.
Dr. Pendekar, I just wanted to ask from you one thing. You said the government at the higher level is committed to palliative care and expanding this across our country. At the lower level, there may be some hesitation.
Yes.
What explains this hesitation? Is it because they
No,
are
it's
worried about either legislation or some
See,
action?
sorry to interrupt you. It's a basic. The medical system, the healthcare system per se, is a system of creating resistance. I'm sorry, I'm a doctor, but speaking like this, but it's a true story. So any change coming in the medical system or a health system, it takes time to percolate down. So if the higher boss says, give this drug, the lower boss will say, no, let's not use this drug. Let's try the old thing. And slowly that drug percolates down to the low level. Same is with the system. So as I said, government of Madhya Pradesh issued a notification from the state at a state level, at secretary level, that morphine should be available in every district pharmacy. A minister and a secretary cannot do more beyond this. But there are a lot of pharmacies in districts of Madhya Pradesh who are just not stocking it. It's so difficult. Now, so government has issued a legislation, but the lower down pharmacy is still not stocking it. They have waived off the procedure of accounting for the morphine because there were issues that there are problems of accounting and a lot of cross checks and all. So pharmacies were not accepting. Government has annulled that. So everything government is willing to do. Government of Odisha has made morphine available in every district of Odisha. Again through legislation. So things are happening. The higher level administration is really very serious. Even the political hierarchy is serious. But we have to really now percolate at a below level. We have to talk to our colleagues at a local level, district level. Sir, please help patients. That's all the message we have to give.
I agree with Dr. Dinesh. Because the government has all this program in place. They have made the rules for morphine availability and everything. But it is the stakeholders, the government level, lower level people, they have to execute these rules and programs. That is what is required. And it takes time in India as usual.
Manish,
Right, Dr. Babu, yes.
So the thing is that why what is the down working? The doctors are not keen on treating cancer patients or all those things. One of the reasons because during the days of MBBS or MD, their exposure to palliative care is very less. So as Madam was telling, now medical colleges are coming with the palliative care department. When the department palliative care comes, we must expose the students, nursing or MBBS, MD from their training days to the palliative care. So that palliative is also to be treated like a subject. See, when you are doing an MBBS or anything, when you see the patients in a palliative care, you will understand how important it is. So after you finish the course and go to a PHC or village, then you will not panic in treating such patients. When you are not exposed to such sort of things, then when you go to a community and you are reported as a primary health care officer, and you suddenly see a cancer patient breathing very heavily and complaining pain, as a doctor you will be panic and you don't know what to explain to them, and you want to play safe and you say no, you take to specialist rather than treating at me. So it's very important that we expose the medical fraternity from the student days to a palliative care. So that's where the palliative care, setting up the departments in each medical college is very, very important. So when medical college fraternity from student days are exposed to palliative care, they will not panic and they will understand how palliative care works. And they will explain to the patient and relatives very conveniently that this is the palliative care. And I think that will make this is going to happen and it will take time.
Right. Dr. Babu, Dr. Tiwari described to us a situation about the 27-year-old patient whose condition was quite bad, but the family was unwilling to accept. She was such a young person, put her on a ventilator, give her the last chance. So, while we are in this program saying that, be aware, know your body, don't undertake risky activities to increase the chance of cancer. We are trying to create an awareness that it's in your hands. If caught early, you have very good outcomes. The medicine has progressed a lot, but many people still are presenting themselves in such a late stage. Now, what do we then communicate to family members, to these patients, on what will be the line of treatment? How should we tell them? Should we lead them on? Because on one side, the outcomes have improved a lot, but on the other hand, the stage at which they present themselves is late. So, communication and expectation management is also very important, both for the patient and the family. So, how is this done? Is this done early on? Is this done during the course of treatment? How do we go about this?
Now, there are two things in that. When a palliative care patient present to you and family members want you to put ventilator or anything, we can't really blame for it. The family wants to do best for their patient. Because they are not medicos, they don't understand. But as a doctor, we must tell them what is the benefit of ventilator or whatever it is. So it's ultimately when a patient comes with advanced stage, it is the counseling. Whether it is a 45 minutes, 1 hour or 1.5 hours, you must give that time to the patient and their family and explain them what is the situation, how we are going to go ahead about it. What is the further line of treatment we are going to go? Whether ventilator is how much is it's going to help. There are many cases in a cancer setting when a terminal palliative care ventilator has very minimal role. So people think that ventilator is something which is going to save life. This has to be enlightened to them. We have to tell them that advanced stages, this is a condition which may help with ventilator. This is a condition which will not help with ventilator. That something medical fraternity has to tell. But as a patient, as a relative, they want to do their best. For even our kith and kins, we want to do our best. But ultimately, we have to tell them it has to be taken on an individual basis cases. So when a patient comes to a terminal stage, when they are going to periphery or something, we must explain and give them the complete outline. Telling that no, if there is any emergency also, if such emergency you require to come to tertiary center. In that some emergencies you need not come. It is going to be an wasteful exercise. Don't come and try to waste your time. So it's basically because of the counseling. That's where if the doctor doesn't have so much time, that's where the healthcare workers, the other social workers, voluntary groups, whoever is there may play a very, very important role. So that's what I was telling you. When you train somebody in a village itself who understand things, when my own mother is telling me that how it is, then I understand it more better rather than try to put more pressure on the doctor. So that has to be dealt in an individual case, and individual patient has to be counseled along with the family.
Right. Michaela, I wanted to understand from you that, medicine has improved a lot. And now we are seeing, many of our experts have told us that we investigate the biology of a tumor and we do a very customized treatment for patients. Over the years compared to 20 years ago, cancer treatment is much more bearable. We've had survivors tell us that they went back to the jobs, they went back to regular lives. Because medicines have improved. Now, what role does palliative care have to play when patients do go through these targeted treatments? It may take time for these investigations to come through. Are they explained? Why these treatments are being designed for them? What is the role of palliative care here?
I think the role of palliative care can take two courses of action. One is always in the information and explanation to patients. I think what was said earlier on, the patients sometimes don't understand or they don't know. I think it's the responsibility of everyone involved in palliative care to make them understand as much as possible, because whilst they might not understand the medicine, they understand their body and they understand their disease and they know how they feel. So I think listening is one element, and that's for everybody who's involved in palliative care. I think the second element is also information on why certain treatments are used and when they can be used and what makes sense and what doesn't make sense, to the earlier point, because sometimes something might be available but doesn't make sense. And I think we have to be transparent and open. And then the other element, of course, again, we are now moving a little bit into palliative care that it's sort of end stage. I think I would like to bring it back also to palliative care in creating awareness and in screening and in disease awareness. I mean, there are countries where you get screened as of the age of 30, or there is material available to help you to screen yourself. I think that's important, independent of which treatments are available. And then dependent on the treatments, as you mentioned earlier on, some treatments when they are in early stage and we lack the experience, they might cause side effects. I think also there it's important to be transparent, to inform the patient as much as possible in as simple words as possible. And then also have the support to take them through difficult times, because even in the most advanced treatments, there can be difficult times. And sometimes it takes the family, the psychologist, the doctor, the GP, the priest, whoever is close enough to the patient to take them through the difficult times. I think that would be real palliative care from diagnose to end.
Definitely. Dr. Joshi, again, I want to understand from you how the community can be involved. Like the doctors have also spoken about, the family of the patient. They have to be counseled, and perhaps they also have to be trained on how to manage the patient. So Dr. Babu had said that, we can get volunteers so that, palliative care reaches the doorstep and it is more humane. You don't have to be a medical expert, but you can be a shoulder to cry on, or somebody they can confide in, and, reduce the emotional stress, or, somebody who can give them spiritual guidance. So what is the role of volunteers and community in pediatric care?
Volunteer has got a very big role to play in a community. As I said earlier, they are the link between the patient, family, and doctor or a hospice center or a healthcare center. Volunteers can do many things like train the family, support the family as a whole. They can take care, they can replace the caregiver for few hours, take care of the patient. They can support the family by like getting the medicine, getting the dressing done. Volunteers are trained in doing all the nursing, sort of nursing care also of the patient. So they can themselves get involved in the care, nursing care of the patient, or educate the caregiver for this. Then they can they have all the knowledge about the delivery of palliative care, like various government programs and all that. So they can guide them to take help of such program. They can also pull out another volunteers, make a group, and help the patient and family. This patient has got many small problems, for which they need not depend on the healthcare center, but they can have that this type of facility services right at the doorstep. So volunteers has got a very big role to play. They can arrange the home care services for the patient.
Okay, so volunteers have an important role to play. That is what Dr. Joshi was telling us. And she was also explaining how they can form groups and then ensure that palliative care reaches to the homes of people. And we've heard from Dr. Pendekar also, who's been saying that this model has been successfully implemented in a few districts in Telangana. And he's hopeful that this will be replicated in many more places. Dr. Tiwari, for palliative care to reach homes of people, how hopeful are you? Because you were saying that system takes time to get implemented, but what are you seeing on the ground in Madhya Pradesh? Dr. Tiwari, would you please unmute yourself? You're on mute.
Actually, I am not much about the government policy, but as the private setup, what we are doing, because as I told that we have well developed the palliative care setup, and we have dedicated team also. So especially for those patients who are in the Bhopal or in the nearby Bhopal, within the reach of 25 to 30 kilometers. Our dedicated team used to go every alternate day, door to door. There is a dedicated team for that visiting also, and they are doing it free of cost. It includes the pharmacist, it includes the trained nurse, the paramedical staffs, as well as sometimes our microbiologists, because look, most of these patients they're suffering from different wounds, this bed sores. So the infection is one of the major the concern for such patients, especially if they are residing in home, and the family members they're also scared that whether that infection will spread to the other the person, especially the small kids in the home or not. So we have the system, but for those patients who are far away from
Dr.
the
Tiwari, Dr. Tiwari, we're having a tough time listening to you.
To educate the community before
I think we're having a little problem with hearing your audio, Dr. Tiwari. Could you turn off your video so that we can hear you better, because we cannot hear you clearly. Can you turn off your video and speak? Dr. Tiwari, we still are having a tough time we can't hear you clearly. But let me try going to another panelist. Dr. Pinyakar, how important is awareness about palliative care? And, you're saying that the government is very committed to this, to palliative care, and are taking it to everyone's doorstep instead of having people travel far distances to get this help, to get this care. So, one thing is to have this care, and the other is for no one to know that this care exists. So, how will awareness be created? Who will be doing this? Will it be the treating doctors and the oncologists themselves? The system that you're envisaging, how will it be? How will it work?
Okay, so I would like to quote you 3 advertisements during Corona. One full advertisement. I'm not talking of one state. So the government of Rajasthan gave a full page advertisement that cancer patient should not worry during Corona. They are just supposed to report to their government district hospitals and they will be offered care. Government of Odisha issued again an advertisement depicting telephone number of an in-charge medical officer from every district of Odisha, and the advertisement said a patient can approach this number on WhatsApp during Corona if he has any problem. Government of Himachal issued a similar notification. Government of Chhattisgarh issued a similar notification. So government is really trying to reach people. Unfortunately, there is no, what you can say, these messages are not reproduced. So government did one advertisement. Now it is the responsibility of other people to spread this message. So there in government of Rajasthan, every district monthly reports the amount of cancer patients treated in the district hospital, the amount of cancer patients receiving chemotherapy in the district hospital, and the same form has a column, amount of people who received palliative care in the district hospital. Same is the proforma in Madhya Pradesh, and same is the proforma in Odisha. So palliative care is happening in the districts, yes, to whatever tune. And during Corona, there was a huge surge of palliative care patients in the district hospitals because they had nowhere to go. They came to the government. So the system is existing. The system is working. Yes, it needs to be strengthened. Government is all in to strengthen the system. But as I said, it really requires involvement of the more people than this. And second thing, if we are talking of building up a healthcare system, we will never be able to build a system if we count on private cancer centers. This is never ever going to happen. It has to be all-inclusive system which includes every member of the society, and this can only be the government. So let us remove our focus from private tertiary level, high level cancer centers offering care and palliative care. This would not happen. Palliative care doesn't give money, nobody wants patients. So it has to be at a government level. Take example of NHS UK, take example of Germany, Switzerland, Canada. The whole healthcare system is public based. It's a public system. And then you are talking of all inclusivity, delivering service at the doorstep, accessing more and more, it should be accessible to more and more people because it's a wider government owned system. So whenever we plan to do some activity, please keep this in mind that we have to empower the states and the state owned system. Thank you.
Right. So definitely the public health system is going to be involved very heavily in palliative care. I'm going to take some closing comments, Dr. Babu. What would you like to say for palliative care? Is it going to be largely something that the public healthcare system is going to deliver? What's in it for the private system? Can both of them work towards this? How does it work? What would you like to say in your closing comments?
I think the one of the things is that 10, 12 years ago, we didn't have any, health schemes from the government side, or they were very less. So around 8, 10 years ago, many states, it started from Andhra Pradesh, then Tamil Nadu, introduced various they try to, encompass everybody into one system. That's what the Ayushman Bharat is all about. The Ayushman Bharat, they majorly concentrate on cancer care. So I will tell you that 10, 15 years ago, patients who never had any surgery or any chemotherapy, radiation for various reasons for cancer, when the government scheme came in, almost now 90-95% people are taking the cancer care free of cost because of these systems. When this system came, the government of Karnataka or Tamil Nadu, what they did, they didn't only involve the government players. They also invited private players who are willing to take up that. And the government paid some royalty to them whenever they treated an patient. So now the government of Karnataka or Ayushman Bharat, what is they are going to take the palliative care also in the same way. So what was 10 years ago, people were not treated and going to home without getting any radiotherapy, chemotherapy are being treated today. Maybe few years line, people who are not getting palliative care today are going to get. So government is very active. I think as I was telling that it will take time. Definitely our health system is very strong and we are going to improve on that. So through the various schemes like Ayushman Bharat and all, I think the poorest of the poor are going to get healthcare system definitely. Either in the government sector or in the private sector. Majorly in the government sector. The government sector is the major system which treats all those cancer and poor patients.
Right. Michaela, let me take some closing comments from you. It is very important to get good palliative health and palliative care. To your mind, in India, are we moving in the right direction so that this is accessible for all cancer patients?
So what I would say is that India is actually moving the right direction. We've heard before that change takes time. The problem is cancer patients don't have lots of time. And I think COVID has shown us that we can learn a lot and we can learn it fast if we have to. And I think my call to action would be let's take this learning and apply it to cancer and move fast with inclusiveness, move fast with inclusiveness of the stakeholders who are involved, and moving the treatment from diagnosis to treatment to the doorstep or sometimes even into the house of patients. And we've had countries where not only were patients activated, but really the treatment was then taken by healthcare professionals even into the house of patients so that they can get treated even in the difficult times that we are facing.
All right. So we need to move fast and implement our systems efficiently. Dr. Pendekar, can you hear me?
Yeah, I can, please.
So what would you like to say in your closing comments?
So closing comments is please make a long-term plan, please make a system of delivery, and please make it time-bound. I don't think to create a system we need years. The palliative care system was designed 25 years back in India, I remember, and unfortunately we are still discussing the same issues. So we have to make a program, time-bound program, and implement it instantly, because it really doesn't require anything. We have everything required to run any program. Thank you very much.
All right. Dr. Joshi, what would you like to say in your closing comments on the role that palliative care plays for breast cancer patients in our country? Dr. Joshi, can you hear me? I think Dr. Joshi is having some connectivity issues. I'll try my luck with Dr. Tiwari. Dr. Tiwari, if you can hear me, what would you like to say in your closing comments on palliative care for breast cancer patients?
So the closing comments is that look, as we know that almost 70 to 80% of our patients sooner or later will go on palliative setting. So we have to strengthen our palliative setting from the grassroots level, whether in the form of creating a system, creating a team, education in the society. All these things are required. And definitely, as Dr. Pindarkar said, it should be done faster. I mean, we don't have much time. We cannot wait for the longer plan. At least we should start with the shorter plan, and the palliative care should be reached to the door level.
All right. Thank you so much for joining us, Dr. Tiwari, Dr. Babu, Michaela, Dr. Pindarkar, Dr. Joshi. Thank you so much for joining us today and talking to us about palliative care. In fact, the way we've spoken and discussed today, it seems like India is moving in the right direction, and palliative care is going to improve by leaps and bounds, and it will be such that it will be available to patients at their doorsteps, and their quality of life shall definitely improve. Thank you so much for joining us today.
Thank you.
Thank you.
Thank you. Thank you.